two other important aspects of this whole metabolic process, which is a combination of calcium, phosphate, parathormone, vitamin D. This is the whole conundrum of what test we should be talking about. Now, calcium is an extreme stimulation, so all kinds of neuromuscular contractility, excitability, nerve transmission, contraction of muscles, hormone action and release, very importantly dependent on calcium. You know that the cardiac myocytes are dependent on calcium, insulin release is dependent on calcium. It's a important transmitter of data between cells. And if you look at phosphorus, it's a very important cytoplasmic buffer. It's very important in energy exchange, and it's a very essential component in the brain and in the nucleic acids in the cell membrane. So, a number of things are controlled by the calcium and the phosphorus. If you look at in mammals, the bulk of calcium and phosphorus is in the skeleton and not actually in the blood vessels. So, it's only a very tiny percentage of the total calcium, less than 2%, which circulates in the plasma. But this small percentage is kept in a very tight range because it influences so many metabolic processes, and calcium by and large would vary between 8.8 to 10.5 milligrams per deciliter, phosphorus around 2.5 to 5 milligrams per deciliter. Important point again, as for important metabolic entities, calcium is always bound to albumin because it cannot run amok free. So, 70 to 80% is bound to albumin and a small amount exists as ionic free calcium, which is the metabolically active component. And one thing which is very, very important to remember is as we do for say T4, we estimate free T4 if we want to take away protein binding, we must know how to calculate corrected calcium. So, corrected calcium is your observed calcium plus 0.8 into 4 minus albumin. So, you have to correct for the albumin value. So, if your albumin value is say 2, then 4 minus 2 is 2 multiplied by 0.8, which is 1.6. So, if your value comes as 6, your actual calcium is actually 7.6, and the reverse of course if the albumin is higher. So, typically when you are looking at calciums in acutely ill patients where albumin might be low, or in nephrotic patients where albumin is low, you need to clearly correlate that as a albumin corrected calcium. If you look at the metabolic balance of calcium, large amounts are actually, it's never steady, it's always in flux. Large amounts enter the plasma and large amounts exit the plasma. Entrance routes are from the dietary calcium that you eat, which is through the intestine, and the absorption requires vitamin D. So, vitamin D modulates calcium absorption through the intestine. That is the basic input route into the blood, and the exit route is primarily the kidney, where excretion of calcium is dependent on PTH. And what is the main storehouse or the buffer is the bone, because it contains 80% of the body's calcium, and as needed the bone will either reabsorb calcium or release calcium as per the need of the body. And again, this process is actually controlled by vitamin D and PTH. These are the recommended dietary allowances, we will leave that alone. If we look at the calcium metabolism, I said there are two important things, PTH as well as vitamin D. Now, the PTH is secreted by the parathyroid glands which sit in the neck. There are two pairs, the right and the left upper and lowers, and PTH what it does really is it senses the plasma calcium, and if it finds that the plasma calcium is going low, PTH immediately goes up, and what it does is increases the calcium absorption through the intestine. It increases bone resorption, so that something comes from the bone into the blood, and it reduces calcium excretion through the glomerulofiltrate. So, by all these three mechanisms, it restores the plasma calcium level. So, when you are talking of PTH, as I said, for any endocrine testing, you must have a pair. So if you are talking of calcium, you must talk of PTH. If you talk of PTH, you must talk of calcium. You cannot look at it as an isolated entity. So the overall effect of PTH is to increase the calcium level in the plasma. Now what about vitamin D? A lot of it has been discussed. This is actually a hormone. It's named as vitamin. It's not formed in the body through dietary sources. It's actually a hormone which circulates in the body, and we know that it's 7-dehydrocholesterol, which in the skin is converted to cholecalciferol, which is hydroxylated in the liver once at the 25 position to form 25-hydroxycholecalciferol, and this then is rehydroxylated at the 1 position in the kidney to form what is called 1,25-dihydroxycholecalciferol, also known as calcitriol. Now the extra vitamin D is stored in the adipose tissue. Therefore, people who take large amounts of doses, let's say 6 lakhs every week for months, and you see their levels say 150, 200, 250, and as sir pointed out, the levels have been remaining high for 1.5 years in some patients. That is because their adipose tissue is full of vitamin D, and it will take a very long time to get out of the circulation. Just to tell you, the person that he mentioned has taken approximately 30 crore units of vitamin D in the past 1 year. So you can imagine the madness that actually prevails in the society. If you look at vitamin D metabolism, this is actually how it works. That the skin produces dehydrocholesterol, cholecalciferol, and 25-hydroxycholecalciferol, and then 125. What 125 does is it increases the intestinal absorption of calcium, thereby increasing the plasma calcium, and if plasma calcium increases too much, it will quickly lead to a negative feedback on the PTH. The PTH will immediately shut the new formation of vitamin D, and it will get back the levels of calcium back to normal. So it's a very integrated circuit between calcium, vitamin D, and PTH. So in most hormone testing, we talk of pairs. We talk of cortisol, it's ACTH, we talk of estrogen, FSH. But in calcium metabolism, we talk often of 4 things: calcium, phosphate, PTH, and vitamin D. And of course albumin, because unless you know all, you cannot just say what is what. So if someone asks you, my calcium is 7.8, you don't know what it is. It could be anything. Now this